Gentlemen,
Hey, how's it going?
we lost one already.
Always, right?
How do we already lose one? We haven't even started,
we
man.
Live.
It's a good thing we went.
Lose me.
I don't know, man. I have no idea. You were the lucky one. You were the chosen one by the internet today. Ironically enough, we were just talking about that. Like, if something happens and then shit just happened.
You know, never jinx the internet gods, right? Right before you go live.
I tell you what, man. I tell you what. Dr. Lane Ochi, how are you, sir?
Good. Thank you for having me. I'm kind of looking forward to this because, you know, I got a funny feeling you're going to test the boundaries of what I feel and think.
I don't know what you're talking about, man. I don't know what you're talking about. Why are you a geek? I mean, what is that? You know, I can tell you that I would not call myself a dental geek because I know there's enough of you out there that can carry the torch. So what does a dental geek mean?
Well, okay. Basically, if you follow me or know me, I'm a dentist in search of a life. Okay, so that's kind of a geeky thing to do, right?
Yeah.
And we've got kind of, I guess, two halves of the same coin, two different sides of the same coin. You know, you're either as a mentor figure, you're either an oracle, right? You go and you advise on experience, you know, things that you've learned along the way, or you are a geek. You look at literature, you look at data, you look at new materials. So I think to be a good clinical wet finger dentist, you need to have both sides of the coin. But most people seem to avoid the geeky side. Well, that's me. I love the geeky side.
Well, if the cement that I use holds the crown in the mouth and it's post 5, 6, 7, 10, 12 years, it's working. That's the geeky side of me, and that's the one I'm going to use.
There's Michael.
Isn't it weird?
I got back in.
Hey, you know, isn't it weird? We just talked about that, and then it just right away happened, Michael.
I got kicked out.
That's okay. You didn't have permission, dude. That's why you got kicked out. But now you have permission. You're back in. We were just talking about talking about getting kicked out. I've been kicked out of a few of those, you know, private admin Facebook groups, you know, for not behaving. I don't even know what that means, but we can talk about it for sure. But Dr. Michael Goldberg, thank you. Welcome. We appreciate you for being here. I was just talking to Lane about what the definition of a dental geek is, and so he was defining why he considers himself to be a dental geek. So I was just saying that, you know, if the cement works, that's all I need to know. I don't need to know about the tensile strength and, you know, the third, fourth, fifth generation. You know, the cement works, man. I've been using Calibra. I've recently changed to Calibra Universal, although Dr. Hornbrook tells me that the total etch gives you much better strength in the final bond versus the fancy words of, you know, Calibra Universal, where now you don't have to total etch. I'll ask those geeky questions probably here in a few minutes, but before I do that.
So you just outsource your geekiness to somebody else.
That's right. That's right.
That's okay.
I go on Chat GPT these days and get my geeky side from Chat GPT. But now that we're talking about dental geeks, tell me, Dr. Michael Goldberg, what does the doctor's dentist mean? You've trademarked it.
So I belong to a mastermind group. Started in about 2006, and mostly dentists. And when we introduced ourselves, we had to tell them about our practice. So I'm telling them about my practice. My practice has mostly health professionals. And everybody was, what do you mean? Said, I started my practice across the street from a medical center. I was on faculty at both the dental school and the hospital, and all the medical people came. And I treated, I mean, hundreds of physicians. So the guy who was running the mastermind group, guy by the name of Charlie Martin, said, "You're the doctor's dentist."
Interesting.
Boom.
Interesting. So do they always ask for discounts?
So that's a great question. And it's something that I had to actually deal with. How do you deal with professional courtesy when you have an entire practice full of professionals? And I decided that I was going to keep my fees. We could talk about fees. I was going to keep my fees as reasonable as I possibly can to deliver the level of care that I wanted to deliver. And that was the courtesy. That was my definition of courtesy. The best that I possibly can. And that was it.
Who defines what reasonable pricing is?
Good question. So, as a coach now, what I discuss with my clients is how much money do you want to make? And I work backwards. So I work backwards to try and figure out what you need to make an hour to accomplish what you want to accomplish life-wise. And then it just has to be reasonable within sort of the constraints of what the highest level of care usually costs. I mean, as dentists, we're not supposed to collude with one another and discuss fees, right? So we're not going to do that, but we know that everybody knows everybody's fees.
Yeah.
So you have a good idea. So I knew what so I knew what the high level crown cost in Manhattan because I knew what the endodontist that I referred to in Manhattan charged. And I knew that his philosophy was, I'm going to charge what the cost of a crown is. So he was charging at, this is, 7 years ago, he was charging like $2,600 for a molar endo. And that happened to have been exactly what I was charging for a crown.
That turned out to be a reasonable price for you to charge a physician.
So again, it's
coming in your practice.
Well, so the other thing is I try to pricing's interesting. The only price that most patients know is their hygiene visit. Otherwise, they have no clue. So when you present a case, I present a case. I don't present it by the crown. Now that's one of the, so I know Lane was also fee for service. So when we're fee for service, I don't have to break it down. Now I do if somebody wants to utilize their insurance benefits, I'd break it down for the insurance. But when I present a case, I don't say a crown is this and a filling is this and here's what you want. Here's the destination we want to go to. Here's the cost that it's going to entail to get to that destination.
Well, I will tell you, Lane, he has told me on multiple occasions that he was the busiest man in Beverly Hills without a website.
Yeah.
And I'm intrigued. I'm intrigued because let me ask you this question, Lane. Do you believe in 2026 that is a possibility of what you created a few decades ago?
I will say that that's a pretty positive yes, because, and I think Michael will agree with me, that the people come to seek the care of a provider not because of the quality, but their relationship and the trust they have in that provider. Okay? Our communication skills are really at the top of what gets people to commit to treatment, right? It's like Simon Sinek's golden circle, right? You know, we're all familiar with the what. We know what we do. We know how to do it, but the most important thing is the patient's why, right, Michael? And if we don't have the ability to communicate, and by that, by really listening to what patients are asking us or saying to us, so there's a difference. And Michael's better at dialoguing about this than I am. That if we don't have that skill, we will never get to our how and what. And so relationship-based practices take a while to establish. And Michael touched on something really brilliant that took me a lot longer to learn than he's just, it was a massive pearl. Learn your overhead. Once you know your overhead, then you know how much you need to make an hour. Once you know how much you need to make an hour, you know how much time something takes you. And that's what you base your fees on for the level of care you want to provide. You know, my practice is filled with movie stars, Academy Award winners, and school teachers. I charge the same fee across the board, right? Sometimes I won, sometimes I lost, but over time it was dead center, right, Michael? I mean,
Exactly.
These are the things we want to go for. And he touched on something brilliant that most practitioners don't think about. Quote, a fee. Full mouth reconstruction, quote, a fee. Because the reality is, if you know what you're doing, it's way more profitable than, doing a full mouth is way more profitable than doing 28 single unit crowns. Because it's going to take you less time to prep. It's going to take you less time to deliver. What's your hourly overhead? How much do you want to make?
But don't we, as we get, and this is the discipline side of this, do we not just buy the nicer car, the bigger house, and the more sexy equipment, and go to the more lavish vacations? And so where do we establish what that price is and what our overhead is? And, do we revisit that every 12 months? Like, my wife wants a bracelet, I got to increase my crown fees now. How does that work?
So we had a process. In March, my practice manager presented me with our fee schedule. And on April 1st, in March we analyzed it. And in April 1st, we made modifications. April 1st happens to be my birthday. So it was my birthday present to me.
It's not an April Fool's joke in there anywhere?
No.
Okay. So this is your real birthday?
So it is.
Okay.
So, but the idea is there was a system
right.
of analyzing what you were generating, what you were making, where you wanted to go.
So did you increase your fees annually, or did you just keep it the same? How was that planned out for you?
Great. So it depended. So throughout my, 43, 44 years of practice, there were about 6 recessions. So you're not only analyzing what's going on inside the 4 walls of your practice, you're analyzing what's going on outside. So if it's, let's say, the 2008 recession, the Great Recession, did I raise my fees during the Great Recession? No. That would have been silly. I didn't drop my fees. But my practice, and I'm sure, Lane, you probably had a very similar experience. My practice didn't grow. It grew every single year. From 2008 to 2009, it was flat. Didn't go down. It was flat. It was the only year I was flat in my entire career. But that's also part of the resilience of a relationship-based practice, and a practice where you educate patients about the importance of what's being done.
So 95% of dental practices in the US, and you guys know that I throw numbers and percentages because that's what I do. But Dr. Brett Kessler, past ADA president, made the statement that there is only 5% of practices in the US that are out of network. And we can, I've argued, by the way, let me share this with the audience because this is kind of fun. Like, why do I have Dr. Michael Goldberg and Dr. Lane Ochi on my show, right? Well, let me tell you, these gentlemen right here, social media is kind of interesting. And the reason it's interesting is because there's a lot of emotions attached to social media with posts and back and forth, yelling, screaming, whatever it is on comments. But over the last couple of years, I found these two gentlemen to be thought-provoking with their responses to my posts and my comments, and they followed through with the conversation. So they didn't give up on just the, this is stupid. Another 95% really are, out of network or in network, and 5%, where'd you get that number from? And then they disappeared. They followed through with the conversation. And I'm certainly, I appreciate that because, today I use a lot of Chat GPT and, I play the social game a little bit as well, for sure. But that's why they're here. They're here because I want to have real conversations, and I felt that as seasoned as they are, as professional as they are, they should come on the show because we can learn from them. And so, gentlemen, I want to thank you for being here. And I told them that right before the show, whatever happens, I don't want them to say "fuck this, I'm out of here" kind of thing, So I appreciate them for being here, and total tremendous respect for that. But to go back to the conversation of 5% being out of network, you're not talking to the majority here. The majority of doctors do not understand what you're saying right now. And so how do you connect with the profession today, 2026, where you've both practiced for over 40 years? There's a disconnect. So connect me with the 95% through your content, please.
Okay, so I look at social media. I get lots and lots of emails about the kind of offerings, CE offerings that there are, and lectures and whatnot. And it seems to me, and I'd love your opinion on this, Cheyenne. Lots of dentists are looking to get out of network. I see drop the PPO as a common denominator in lots of conversations. So, and what I see strategically promoted, I don't believe is the right pathway towards dropping PPOs. So I practiced before PPOs became a really big thing, but I was across the street from a medical center, and the residents and the nurses and the ancillary staff had dental insurance. When I first started, I accepted what the insurance was going to hopefully pay as payment towards what the total fee was. So I accepted assignment of what the benefit was. I quickly realized that that was a lose-lose situation because it was taking way more time than my front desk, which was 2 people, could handle. And when the insurance company sent the check to the wrong person, it was just, I was playing their game, and I didn't like it. In 1984, my office manager came to me and said, "You know what? This is crazy. Either we have to hire another person or we have to change what we're doing because this is driving us nuts." So I said, "You know what? Okay. I'm going to drop dealing with insurance companies entirely. Patients will get a super bill, and they can go deal with their insurance companies themselves. I fully expected that when I did that, 25% of my patients would leave. The nurses would leave, the residents would leave, the 1199 hospital workers union would leave. And in anticipation, going back to fee setting, I raised my fees 25%. I wanted to make the same amount of money. I figured I'm going to lose 25% of my patients. Guess what happened?
You made 25% more money.
Yes, because nobody left. A couple of people left.
Yeah.
And they eventually came back. Most of the people who left eventually came back, and it taught me a really valuable lesson. That it wasn't about the money. I'm probably older than Lane is, and I've had some medical issues. Okay. When you put your trust in a healthcare provider, it's blind. Even someone in the health professions, you have no idea. Somebody puts you under anesthesia, you have no idea what's happening. You have to trust that person.
Yeah.
Something that we dentists don't really appreciate enough, frankly, is that the mouth. Remember the homunculus in school, right? How the brain sees the body from a neural pathway perspective. A lot of attention is around the mouth. We don't really give the gravitas to what that really means. Putting our hands in a person's mouth is really, really personal. Sort of like an OBGYN. My wife didn't want to change her OBGYN for anything. It's very, very similar. And, I want to go back to something that Lane said. I don't want to skip it because it's also brilliant. He brought up a book. He brought up a book by Simon Sinek. I didn't learn a lot of the things that I learned from other dentists. I learned a lot of them from books. Simon Sinek's Getting to Yes. I'm sorry, Why. Jim Collins' Good to Great. Patrick Lencioni's The Five Dysfunctions of the Team. I mean, I could go on. None of them are dental books.
Yeah, but who reads books today?
So you can listen to them.
No, but listen, I love what you said about trusting your healthcare professionals blind. That gave me goosebumps. Seriously.
Can I backtrack to Michael and build on what he's talking about?
Yeah,
Michael, when did you make that decision to drop? Let me rephrase that. How long had you been practicing when you made that decision to drop PPOs and raise your fees? How long have you been in practice?
So I was an associate for 4 years, and then I started a practice using the base that I had when I was an associate. That was the deal. I sort of built a practice within a practice, and I took that practice elsewhere. So it was total of 8 years, 7 to 8 years after practicing. And I know where you're going with this, right? And that's when I made the decision.
Right. So Shaheen, if we're going to go tie this all together, your question about, well, my wife wants this, and do I raise my fees? When do I raise my fees? The problem is, and I think this is where we do our younger colleagues a disservice, and that the practice of dentistry is a long game. Okay. When I mentor people, I break it up into 3 phases. First phase is survival. The second phase is growth. And the final phase is income, where we really make our money. Each phase has a set period of time. So what Michael did is made the decision is he was firmly in his growth phase of his career, wouldn't you say?
Absolutely.
And that's where you've committed patients to trust you and follow you. And this is the most powerful thing that we don't share with younger doctors, right? It takes a little bit of time, but if you invest that time and you invest it wisely with your patients, oh, the dividends are there, aren't they, Michael?
So
that's
let
a big
me ask
deal.
this question real quick, because I love what you just said, Lane. That's, because I agree. I think I'm in that income phase now in my career, 25 years out.
Yep.
Right. But I'm not in my income phase as you traditionally would think, because I'm starting my 6th practice tomorrow. And so I think that growth is not necessarily growth with patience per se. It can also be growth with wisdom and knowledge and skills. And I mean, there's a lot more attached to that growth phase than just income by itself, because I lost all my money in 2008. And again, I lost all my money in 2022. So, but that growth was still consistently happening.
Right.
Go ahead.
So no, I was just build on this, right? So there are so many facets that we have to take in consideration, right? When we talk about intuitive decision making, right? It's based on experience and success, and the more we experience, the more successful we are. We get more confident. We get faster. So that you built through that part of your practice and professional development. Then your wisdom comes in to build on top of it. So we go into our system 2 thinking. And so when you can bring both intuition and logic into any practice at any point, right, the person with the most experience is going to have the most success. I've seen people, Michael, you know people like this who have literally retired from dentistry, moved to another city, and decided, I'm really bored. I want to start another practice. And because they have that experience, right, they can start a successful practice, just like you're experiencing now yourself, Shahin. So this is great stuff.
Well, let me ask you this, because I want to dive a little deeper into the survival mode, because there are a lot of new graduates in heavy debt today. Mm-hmm. So how do you define survival mode for those doctors that are 10 years or less out of dental school?
I would describe it the same way. I was in survival mode, and I experienced survival mode twice. So, I mean, as a dental student and probably the first 3 years of my career, it was like, it wasn't top ramen. It was mac and cheese. I was really excited when I could get 5 boxes of mac and cheese for $1. I mean, it was no eating out, just bare bones, keep it simple. Drove a used car that was just reliable. But the thing is that we have to be careful that we don't get into, well, the philosophy in investing and just out there is that debt is opportunity. Well, yes, in some situations, right, Michael? But debt can kill you too, and that's where we make mistakes. I think probably the greatest thing that ever happened to me was learning that you could live cheap, because the second financial Armageddon in my life is giving away half my net worth in my 40s. Right. So I got divorced, and I paid a lot to get out because I needed to get out. So, and it was kind of cool because it was a very humbling experience, because I was right in the really high growth in part of my practice, and I was getting really entitled. Like, I deserve this. I'm really good. Right, Michael? Yeah. You know that happens. And so when I got divorced, I learned to live below my means again. And from that point, believe it or not, I accumulated more net worth because I hit income and the timings. So understand what debt you really should incur is just critical. All right. You're not.
So how do you define risk then, as far as debt? Because a lot of times, you have to take a risk, and you
Right.
go into what's considered good debt versus bad debt. So how do you define that in that survival mode, young dentist?
That one is going to be really personal. I mean, I hate to say it. I cannot control and advise people who aren't comfortable with the fact that my journey, my pathway was probably more frugal than they're willing to do. Okay. It's hard to do. But the thing is that you have to set, and I hate to say this, you have to set a budget and you have to have the discipline to stick to it. And I don't think just like most people don't really know what their overhead and how much they make, right, Michael? They don't know how to set a budget. I mean, Mark Twain said it the best. The race is rarely won by the hare. It's always won by the tortoise. As I told you just a few minutes ago, it's a long linear progression. It takes a long time to get to where we can actually start spending money, in ways that we can reward ourselves, be it a nicer car, be it our first home.
So Michael,
someone needs to be responsible.
Yeah.
And my story is I wasn't. My wife was.
Yeah.
So we were a great team together. Still are, thank God. 53 years. She has an accounting background. She set the budget. And if I wanted to spend, her first reaction was no. I had to justify it.
It's always a no
Now,
first.
most dentists don't have that control mechanism.
Well,
So
hold
they
on a
just
second.
spend.
Hold on a second, Michael. So I thought the best thing for us to do is to marry our dental classmates. You're saying we should have married a CPA. Okay.
You want to look, we all
That's
have
smart.
strengths.
That's smart.
You want to marry somebody with complementary strengths, not the same strengths.
Yeah, but my crowns were better than hers. You know what I mean?
So Michael, do you want to know how smart I am? My second wife, controller for a Fortune 500 company.
Okay. Exactly. So we're giving you the formula for success.
Yeah.
Marry
someone who knows money.
I hear what you're saying, Shahin, because I've been teaching on and off since I graduated. So I see dental students all the time. I'm still teaching it at Temple University. And I feel badly for these kids. I feel badly because something changed in the 90s. I saw a material change in the reason people went into the profession. Prior to the 90s, it was pretty idealistic. I want to help people. I want to do good. I want to be involved in people's lives. I want their relationships. In the 90s, things started to change, and it was a shock to me because students would come in for interviews and they would come right out and say, when someone asked, why'd you become a dentist? They'd come out right and say, I like the lifestyle. I didn't want weekend call. I didn't want to go in at night. I wanted to be in the healthcare profession, but I liked my dentist lifestyle. We set these kids up for, I think, an unrealistic expectation. What Lane was explaining was that he lived within his means. The kids in dental school are already living beyond their means. And they're $500,000 in debt.
Yeah.
So when they get out and they're not making, you think about if someone's, I think the numbers just came out. The ADA, I think, just came out with the numbers. Average is $250,000. I think that's probably wrong. It's probably higher, but let's say it is $250,000. What do you have to make in order to pay off the not even the principal, but the interest on a $250,000 loan that's at 7 or 8%? You have to make a pretty darn good living.
Well, I
And
did
then you
I
have to
did
live.
I did a quick numbers thing that it comes out to about $85 an hour when you work full time, 160 hours. If you work as a W-2 employee.
So what does
And
that come out on a yearly salary basis?
well, if you're at about 38%, and my math isn't great, but if you're about 38%
No one's at 38%.
tax,
Oh, a tax. I thought you
yeah,
said
if you're taxed at 38%, which is pretty standard as a W-2 employee,
well,
right?
you guys are in California.
Yeah. Well, um,
I'm not much better in New Jersey.
yeah. So, I mean, we can have that conversation too, but let's say 35%. I don't know. Some, with doctors were always, 38%, right? I pay 32. Okay, whatever.
We don't
35%,
know our
right?
overhead.
Yeah, that's right. I mean, we're just winging numbers, right? But the point is you have to basically have a net income out of a location of, and this is something that comes up on social. Somebody's bragging about making $500,000 or $600,000. Well, think about if you're at 30% and you're getting $500,000. I mean, you're over 1.6, about give or take 1.6 million in production, adjusted production, right? So adjusted production, you're at 2.2 million, true production. So, it's not easy to get to that level, but then now you're a W-2, and that 500,000 exposed to 35%, you're coming home with a little bit more than half of that. So you're right around $300,000. But that's on the high end. We're talking about paying back debt. Typically, a young dentist is not as well versed to do 2.2 million in true production. So they're coming home with net of 300,000. Take 35% tax, you're at 185, right? Well, at 160 hours, that's $85 an hour, which is what hygienists make today. So, that's the challenge. That's the challenge in that survival mode of, and you're absolutely right, is the expectation of the doctor going, wait a minute, I got the Beamers and the Maseratis and the hot girls. And now you're getting $85 an hour take home, which is the math, I think, is what, 15,000 a month. And, 6,000 goes to income to paying off your debt. 7,000 just so you're living off of $8,000-9,000 with, all the extra. So that survival mode is a very difficult phase today.
Right.
For the doctor that's working HMOs and Medi-Cals and PPOs. And that's why I said they don't relate to you guys talking about charging $2,600 for a crown.
But there's a reason it's called survival mode. I mean, it's you just got to hunker down, right?
Yeah.
And that's a hard thing to do, especially when you're young and invincible. It's easy for Michael and I and even you to say, yeah, I understand, live below my means, but that's a lesson. Consequences. Our brains just aren't wired to understand consequences, and even as young graduates. I mean, I don't think I really fully appreciated the consequences of most of my decisions until I was in my late 30s.
Yeah.
So it's the Dave Ramsey philosophy. I think a lot of dental students would benefit by listening to Dave. Not that I buy into all his thing, because he's totally debt averse and I'm not. I think there's good debt.
Yeah.
I mean, I think my house was great debt. I didn't have the same, unfortunate situations as you guys did, but I did have one, which was a failed partnership. When I left academics and I opened up another practice in Midtown, I went in with a couple of partners, and that did not go well. And I lost about $1 million. But it was $1 million I could afford to lose because I had leveraged my home. And so I was able to replace it fairly quickly.
Well, let me
It's
say, let me. I think this discussion could really continue and carry on, and I think ultimately what I'm hearing the two of you say is understand your expectations very well, understand who you are, and understand that it is what what is called, which is survival mode, which is don't have these high expectations today coming out of dental school. You have to pay your dues, and I think it's fair to say that first 10 years is part of that process of learning not only who you are, clarifying your path as far as what you want to do in the profession. But I want to shift gears a little bit here because Lane, I have to tell you, I want your geeky side a little bit here now because Tori, if you can put that photo that we looked at, that open bite photo, yeah, that one. So Lane, you're the occlusion guy, right? Talk to me a little bit. What are we looking at here? Because look, here's the reality. And I think this is a great segue into this because that young dentist in the survival mode needs to learn how to do this type of dentistry.
Mhm.
These are people that walk into your place of business. Now, you could hide underneath the umbrella of I'm an associate, I don't have to pay attention to this, but you get 30% of production out of your associateship. And if you learn the skill that these gentlemen, seasoned gentlemen, are talking about today and really take it to heart, you can still have great success being an associate. And you don't necessarily, and we've talked about this as well on my channels, that you don't need to be an owner to be a successful doctor. And a lot of doctors shouldn't be owners. So don't think that this is not something as associates you should handle. So Lane, what am I concerned about here?
So, I think within your question, there is a simpler question, and that is, what should your decision tree look like when you stare at a case like this? So I'm just going to pull. I don't know if you know, but my teaching partner is Michael Melkers, and he created an incredible restorative mantra that I'm just going to completely steal. And Michael decided if we're going to write if the chapters of the ultimate restorative occlusion textbook is made up of 3 chapters. How do you want it to look? Or how does the patient want it to look? How do we make it fit? And I changed the last chapter to how do we keep it from breaking? So we can look at this case and work backwards from what are our concerns to keep it from breaking? And then that'll tell us how do we make things fit together? And then finally we can work and look at how does the patient want it to look? How do we want it to look? So I look at things across the board in both ways. I bet if I were Michael, he's going to look at it the same way, functionally and aesthetically, right, Michael? And so, no, you're not. Okay. So that's okay. I want to hear his thoughts. So when I look at this case right now, I'm seeing somebody that exhibits parafunctional wear. The first question I would have to ask is, what does this patient want? And we go from there.
So, what do you? So we talk a lot about informed consent, pros and cons, risks, and so my question to you is, what is your conversation with the patient as far as obviously this patient in this case, and I use this in my post today that said the patient wants a better smile. A smile enhancement was the chief complaint here. Asymptomatic, 70-year-old male, does have sleep apnea, and I know Michael got excited about that. I just sensed that for some reason. But Tori, go back to the open bite, please. And so what's your communication line? I mean, okay, the patient says, I want it. What are you talking about with the patient?
Well,
you what?
go ahead, Michael.
So I could have predicted that he has sleep apnea based on that picture because he's guarding his airway. He has a narrow maxilla. And we don't have the occlusal view, but you can see he has the left-sided crossbite, probably a functional shift as well. So his tongue space has been restricted. And that is a predisposing factor for sleep apnea. And you look at the wear pattern, and he's protruding his teeth to guard the airway. And that's what's contributed to the wear pattern that you see. So I go back to how did this occur? Now you could, you say, well, he's 70 years old. It's typical wear. No, it's not. It's not typical wear. This is parafunctional wear, secondary to, in this case, sleep apnea. And if you're not going to address the cause, whatever you're going to do is probably going to fail. Now, it may not fail in the short term, but it will in the long term.
So what's short term and what's long term?
I gave up my crystal ball.
And that's the challenge, right? Because this is a 70-year-old patient.
Why should we have a crystal ball? Why should we accept the responsibility for predicting? I mean, there's no dental calci. I mean, why should we accept the responsibility for predicting when things are going to fail? We see the problem. We know it's going to fail. I can't tell you when. I can tell you that most likely it's going to happen the day before you go away on vacation.
So if it fails in 15 years, is that a failed case?
That's a question you can only decide 15 years from now. But you can't predict that it's going to last 15 years.
Well,
we fall into a trap. We fall into a trap by people asking us, well, how long is it going to last?
Right. Let's ask the better question. Who's the stakeholder in all this? Is it us or is it the patient? And this is the whole basis of the co-discovery, communication-based treatment planning that Michael and I have been alluding to, of building trust, right? You asked a question a little bit earlier about, what do you tell this patient when they want something that, and I think you're asking, that we may not want to do for them. Well, informed consent, you were mentioning. It's important to understand something that, patients can't actually consent to treatment we know is below the standard of care. Right? They can't do it. Trust me. I'm a legal expert. I'm a med mal expert witness. You can't do it. Yeah.
You don't want to go into court and try to justify an informed consent because the judge won't take it.
Exactly.
So let's talk about that for 1 second, because doctors get sued. Why is your expert any better than my expert?
Okay. Let's really, this is the best distraction point to the point that Michael has been bringing up. The number one reason, right, Michael, that doctors get sued is a breakdown of what?
Communication.
You notice we said it at the same time.
Because we've both done legal reviews. Yeah. We know that it's not only the doctor that does below standard practice that gets sued. It's the front desk that wouldn't return the calls or that didn't tell the doctor what was going on. That gets people angry. Mm-hmm. People don't sue friends. If my patient thinks of me as their friend, as their advocate, they're not going to sue me. I've never gotten sued.
But let's say let's say I've been sued twice, and we can get into, one was my ex-girlfriend, so that's we can get into that discussion.
You didn't get sued over your dentistry.
No, yeah, right. The other was another dentist who was a CR doctor who didn't believe in opening verticals in neuromuscular dentistry. And so, and she, it is what it is. But I've been sued twice. So I've gone through the process, and I can tell you that it's a shit show. It's what it is, because the reality is, and I say this all the time. Look, the only winner is the lawyers, right? We know this, right? So you two are taking my case, and you both are experts on the plaintiff side and the defendant side. Who's right? Who's wrong? I mean, lawyers don't know what your clinical argument is.
I'll go you one better, right? I've not only been sued by a crazy patient. It was my own damn fault. She fired me and I took her back. So I violated number one red flag rule, right? My ego got in the way. Anyways, her case was so bad that her husband, who was a retired district attorney, handled the case, not a med mal attorney. They couldn't find one. Went all the way to court, spent 6 days in court, and the jury found unanimously for me in 45 minutes. So trust me, I just heard it out of your voice. You never want litigation because it will destroy your stomach lining, your self-worth. I was gun shy to pick up a handpiece for a big case for about a year after that. So the point being, going back full circle, is again, develop the relationship and the communication skills so that the benefits and considerations are fully understood, and that you can modify the treatment with co-discovery with the patient. Like, it doesn't have to be a comprehensive full mouth reconstruction with arch widening, opening the vertical, right, Michael? There are phases that we can address and still improve the ultimate outcome.
So Tori, let's talk
about this case.
Yeah, Tori, put up the photo again, please.
So he has sleep apnea. Is he being treated? It's been diagnosed. Is he being treated? We know that the most likely treatment is CPAP. We also know that the compliance rate with CPAP is terrible. If he's not going to comply with CPAP, this process is going to continue, and it's going to destroy whatever you put in there. So do
you walk from the case?
What? No.
What do you do what do you do for this patient that wants a better smile?
You give them the better smile, but they have to wear an appliance.
What's that appliance?
So in my hands, it's some kind of mandibular advancement appliance that's going to also help his sleep apnea. So I'm trained as a sleep dentist. So I can make that appliance, or I can refer him, if I'm not, I can refer him to somebody once I've restored him to make that appliance. I believe that anybody who's been diagnosed in sleep apnea, and we can talk about this because there's going to be a pill coming out soon in 2027. RD109 is a pill that's it's in phase 3 trials right now. It's a pill for sleep apnea. They already have Zepbound, which is a GLP-1 for people with sleep apnea, but this is going to deal with with opening up the airway itself, and it's going to be a real boom, I think, for dentistry, not for sleep dentists as much as it is for regular dentists, because I believe that the pharmaceutical companies are going to market the hell out of this pill because doctors love prescribing pills, and it's going to increase awareness for sleep apnea. And it's going to, if you can network with a physician who has patients with sleep apnea and to get them to understand what the impact of long-term sleep apnea is on the mouth, on the occlusion, on the TMJ, you become their best friend. And all I want from a physician, so I'm the doctor's dentist, right? So all I wanted from a physician is to ask their patient, when was the last time you saw your dentist? I don't want him to ask any other question. That's it. That opens up a conversation because most of them will say, well, I don't really like my dentist. Do you have a good dentist? Boom. Guess who gets a patient?
Is there a difference between positioning the low? Well, I want to ask this in a way to look. Here's the real question.
I'll save you because I know where this is going to go. Right?
I don't know, but go ahead. Let's see. Let's see where you're at with this.
So going back to this case and trying to funnel this down to what Michael's talking about. Right? Prologue's a predictor of the future. So how do we break the pattern? One of them is an appliance. Okay. And now a lot of people argue, well, we don't like sleep apnea mandibular advancement appliances because they change the occlusion. There's all sorts of comorbidities. But you know what? I'll take longevity over occlusion any day, right? Most patients will. But when we say we're changing the occlusion, well, isn't that what we want to do with the rehab anyways? And by the way, teeth that are that worn are in the wrong place anyways. So, is it really a sin to change their occlusion?
That's a great question. So this will lead into the question I was going to ask Lane.
Oh, good.
How would you do a full mouth rehab for that case? How would you?
Well,
Tori, show the picture again.
That's okay. So Michael touched on it. Okay, that we understand. You never do a case. You never pick up a handpiece till you understand what the end is. You have a full understanding and the patient has a full understanding. And to get there, it takes steps. And so I always, when I work up a case, every case has a phase and a fee associated with that phase. We do not move forward to the next phase till we are satisfied and complete the previous phase. So I'm a show me kind of guy. So to what Michael's building on, I see sleep apnea issues as well. I want to start them in some sort of appliance. It's phase one. Okay. It'll do a couple of things. It'll prove to me that they're wearing the darn appliance, right?
Bingo.
And they'll continue to wear it after we've completed the final phase. So that would be phase one.
So now, what kind of appliance in phase one do you recommend?
Now, this is an interesting one because it depends. I do not like a full arch Tanner or Michigan for a parafunctioning patient that may have OSA because they tend to clench on them and close the airway. That's okay. Give me a moment here, Michael. If you're going to do one, then consider mandibular only, not maxillary. But I prefer like a midpoint, anterior midpoint stop appliance that allows separation of the posterior teeth. Hold on. And believe it or not, and this is really cool, Michael, because I've done these for a lot of OSA patients that are on variable pressure CPAPs, and their pulmonologists all call me and go, "What did you do?" Because their pressure recordings are going way down, and every one of these pulmonologists all happen to wear CPAPs themselves. It was hilarious. They all came in and we made them an anterior midpoint stop appliance, and they go, "Oh my God. This is great, my CPAP pressure," because it does something kind of interesting. It keeps the teeth slightly separated and allows that freedom from movement rather than that parafunctional. The alarms are going off because you're not breathing and they smash their teeth and come forward. It just allows them that freedom. So that's where I start. Once I've relaxed, deprogrammed the muscles, you know what? Pick your poison. I'm a CR kind of guy, but I define CR as an orthopedically stable position. And sometimes that is a slightly translated position. So, it just depends.
So I think, and I'm sure, Lane, you would agree, what also has to happen here, which oftentimes doesn't, is you really have to analyze the TMJs. You see, I have to see where they are and whether or not there's any pathology there. Just because they're not symptomatic does not mean that there's no pathology there.
Yeah.
And if you're going to put any patient in an appliance that's going to change their bite, you might take an unsymptomatic TMJ patient into a symptomatic TMJ patient, get really angry at you.
Yeah.
So
I always image at bare minimum CBCTs of the condyles before we start.
yes,
That's part of our data collection.
same thing. Now, you might look into the Ripple appliance, Lane. Ripple is an anterior stop. It's a maxillary and mandibular device with an elastic that prevents the mandible from falling back.
Yeah.
Because that's what happens with sleep apnea. You lay back and your mandible goes back. This prevents it from going back. You can set it to any anterior position you want. You can advance it or you don't have to, but it has an anterior stop. It has almost like a reverse. What were those things that we used for dentures? I forget. But anyway, it's sort of like this. Maxillary mandibular has a pin that goes into this plate and it keeps it in the position. So something to think about. But the point that Lane made, which was so important, was you're letting the patient prove to you that they can do what you're asking them to do. It's sort of like perio. You have a perio mess and your patient's not going to take care of their home care. Are you going to restore them? No, you're going to make sure that they can maintain what you've been what you're doing. So until they prove to you that they can do it, why proceed? If they're not going to be able to wear the appliance, okay.
Yeah. We used to call it the perio penalty box, and it was part of our human behavior to try to learn more about the patient before we ourselves committed to cases. And I think that these are, this is why I'm a dental geek, right? I love geeking out to stuff like this because you could see these conversations go in different directions, and we each learn something. And by the way, Shahin, what I really want to compliment you on is the concept of what you are globally trying to do. And that is, dental school sadly graduates competitors, right? If we're smart when we first get out, we kind of become colleagues. And, we just play nice with each other. We try to develop referral networks. But you know what? The apex of where we want to be is collaborators. We want to be able to have these open, honest conversations with each other and, learn from each other. And so my hat's off to you for what your mission is, because it's not missed to people like myself and Michael, that you're trying to bring, the profession together and be helpful, raise everybody's bar, right, Michael? Thank you.
Why is it that only the two of you understand that and nobody else does? Can somebody help me with that? Thank you, Lane. I appreciate that. I'm, the famous saying is you get 3 doctors in a room, get 10 doctors in a room. They all have a different opinion on how to treat that case, right?
That's okay.
And that's the argument I have on the expert witness side is that, who's really in the room? It's the doctor and the patient that are the two people that really know what happened. To your point, there was lack of communication or of communication failure. And here we are in court having a debate about who's right and who's wrong, right? But I do think we can all agree to this, is that phase 1 demands some type of a reversible type of an appliance to see how this patient does. The fact that they're asymptomatic doesn't mean you just start cutting teeth, because you're right, they can become symptomatic. The fact that they, and I think, Lane, you were very nice in the way you said, I'm CR, but I can go either way. Well, not every doctor's that way. It's like, I'm CR and I'm CR. And what I was going to argue is to say, look, if the sleep dentist says, in order to put and create more room for the tongue, the jaw has to come down and forward, why then in CR are we pushing the the condyle up and posterior. That's
You know,
that's a total conflict in
so
the
so
thought process.
I did a paper. Oh, so I studied orthodontics. It was a 3-year course, and I did a paper on the definition of CR. Do you know how many there are?
13.
More.
I think I counted 15.
Okay.
But the point is that your definition of CR and my definition of CR may be very different. I happen to like Lane's definition. He's not a CR, purist. It's
Hey,
it has to do with function as well. Where are you functioning?
let's put it this way. What is CR? All right. CR always has been and has not and always will be, and it's nothing more than a point of restorative convenience. That's all it is.
Yeah. So then why are we so hard about it? I mean,
Well,
Coyce talks
I'm not hard
about, and
about it.
well, you guys aren't, because you've experienced, realize this: when you're 3 years out, you only know one way. When you're 40 years out, you can skin a cat many different ways, right? But the point is, Coyce comes out with a deprogrammer, and it's basically kind of an NTI in a sense. It disarms the muscular activity of the masseter and the temporalis. Well, that's what neuromuscular is, in essence.
Actually, the thing that we have to consider is how high of a functional risk is the patient before you decide
Right.
where you want the starting and ending point of your condylar position and your occlusion to be. And that's why Michael hit on it. Bigly, take a joint image, even a bone joint image, a CBCT, will give us some insight to where that patient is functioning. And you may find that most disc displacements aren't symptomatic, because many of them are medial and anterior. And that's, you're never going to walk that disc back if it's chronic, or if they've been functioning on the retrodiscal tissue. You can't recapture a joint. Disc. So
Wait, it's how many people do a range of motion
right,
as
exactly.
part of their exam?
Mm-hmm.
What's their range of motion? You can tell by someone's range of motion what's going on to a large extent. But I wasn't taught to do that in dental school. No way.
Both the cases I got sued on were full mouth rehab cases built on neuromuscular dentistry. And here's what I want to tell you is that the handpieces and holster a lot more after those two experiences. Because
PTSD.
the reality is neuromuscular is still today not mainstream. And it's very easy to find the CR experts that are prosthodontists and orthodontists and periodontists and you name it, to go, what? Like, this guy is doing voodoo dentistry. And I'm like, hold on a second. Like, these patients are healing in my hands. One breaks up with me, the other just didn't want, for another reason that doesn't really matter right now. But the point is it works. And why should I go through all this shit to try to say, look, man, CR, it's not a occlusal debate. It's just a patient-doctor relationship. And that's why one expert on the neuromuscular side and one expert on the CR side, they're both right. They're both right. The problem is the communication breakdown between the patient and the doctor.
Yeah.
So, but let me finish this thought, please. So here's what I learned. What I learned is if you got a case and somebody's paying you more than $25,000, lawyers are going to like that if it goes south. If somebody's paying you for quadrant dentistry or single tooth or, I don't know, a small 8-unit smile makeover, the odds are they're paying you obviously less unless you charge $2,600 a tooth, and they're paying you less. And Lawyers are not as, it's not as sexy for them. Sorry, Lane, go ahead.
No, you're sharing this story. I've shared, and I'll tell you, for those who are listening along, this is these stories. My story of being sued and spending 6 days in court. Your story of 2 lawsuits. These are gifts. Please understand, people who are listening. These are gifts. These are things that nobody talks about, right? We don't want to talk about them, but if we don't learn from them, then they are no longer, they just will haunt us forever. But it goes back to doing things in phases, right? How do you approach a patient that you're going to build them forward? You put them in orthopedic appliance for a long time. Make sure they're comfortable, right? Before you proceed.
So that's really, I think, the key is when someone has a complicated case like this, you can't rush it.
Yep.
Despite how much pressure the patient's going to put on you. And I think that dentistry today has gotten into a pattern of same day service, right? Teeth in a day, same day crowns. You can do everything immediately. Immediacy has become a selling point. But when you're doing these kinds of cases, you will learn as much from looking at the patient's temporaries as you will from anything else.
I'm going to ask you a real question in real time right now. I have a case right now. It's tooth number 13. Okay. I did a smile makeover for a patient 12 years ago, 10 units. Loved it. Never heard from her. Calls me a year and a half ago, or something like that. Breaks number 13 in the cervical third. Everything else is intact. That usually is kind of an occlusion, parafunction. We can talk about all that, right? Comes in, I prepped a 3/4 crown. I re-prepped a 3/4 crown. Tooth becomes symptomatic. Referred to endo. Endo does the root canal. 3/4 crown goes through the 3/4 crown, does the endo. Patient is still symptomatic. So the endo takes the root canal out, retreats the root canal, puts calcium hydroxide in there for 6 months, I believe it was, to see if the tooth would calm down. Didn't. Right? Talk to the endodontist, and the endodontist goes, listen, man, I'm looking at the root of this tooth with a microscope.
What about a CBCT?
And a CBCT.
Okay.
And I don't see a crack. I don't see any canals missed. I don't know what is going on here, right? So then I go, okay, look, it's out of the scope of my training. X-ray looks great. Crown, 3/4 crown looks great. Root canal looks amazing. She goes to 2 other endodontists. Root canal looks amazing. So now there's this mindset. So we talk about non-odontogenic pain. She goes, and I don't know what she does, sees a couple of different people still in pain. Right? And guess who's at fault at all this? Me.
Why?
At least that's what the patient thinks, right?
Why?
So, well, it doesn't matter why. That's what she thinks. She came in with no pain. She had a broken tooth. She left my office. She went into pain. I did it. So now here's the question for you, gentlemen, because I'm 50-50 on this and I'm leaning towards a no. She wants me to crown the tooth because she went to some oral surgeon that said, you know what, just because in the microscope and just because in a CBCT, you can't see a crack or a missed canal or something, there's probably some hairline fracture that's missed. And if you crown the tooth, that can create the tooth from not being so hot, right? And we know what real dental emergency is, right? I mean, a patient in true dental emergency status, they they can't sleep. They can't, right? So anyways, so my question to you is, and I'm here in my head going, there is no reason for me to go back in. You go in through the crown. You've already removed a lot of the tooth stump. If I get the crown off, now I don't got a lot of tooth stump. I'm building it on a buildup on a lingual wall, and that crown might not even stay on, right? Because I'm building it on buildup material. So I'm leaning towards saying, I'm pounding sand. I'm not prepping a crown. There is no diagnostic reason for me to prep a crown. So my question to you, gentlemen, is this. Well, is there a big difference between a veneer in this situation, a 3/4 crown, and then crowning that tooth, knowing what I just explained to you?
So you want the geek answer? Is I agree with you. You want the empathetic, all-wise oracle answer is, the patient doesn't know either. They're just seeking to blame something. You just happen to be it. And sometimes this is where slow walk dentistry really comes into play. I would probably I don't know this patient. The relationship bothers me because she stayed away so long and only came back. Right, Michael? That there's a huge
red flag.
Exactly. So the question is, you have two choices. You either cut bait or do something that you are comfortable with without committing. And that may be a slow walk procedure, which is just, let's retemporize this tooth and give it 6 months.
Retemporize with what?
Just
take it out of occlusion.
Just take it out of occlusion. Just whatever you want to do.
Okay. It's already out of occlusion, but I understand.
Yeah.
It's already out of occlusion and it's still symptomatic.
Still symptomatic.
Mm-hmm.
And you're in San Diego?
I am.
So I tell you what, I don't know. I know San Diego, but what I would do if I were in LA, I would send her to UCLA oral facial pain. Say, listen, you know what? I have no idea what's going on here. You've gone to 3 endodontists. We don't have an answer. Without an answer, we don't know what to do.
And my empathetic side is just wants to hug her and help her.
Yeah.
It's like I'm like,
yeah, and more power to you. That's why the slow walk sometimes is.
It's been November the tooth was retreated. Mm-hmm. We're going on 7-8 months now. Anyways, and I don't want to dive, but here's the point. The point is these are what real dentists deal with. These are what real life dentistry is about. And it kind of puts me into this. So to finish my thought, I'm not going to prep it for a crown because I think there's no diagnostic reason for me to do that. If the endodontist said, there's a fracture, okay, fine. But now she's thinking about extracting the tooth and placing an implant.
So the real question. Haven't you had? Okay. I've had stories. I'm sure Lane's had stories.
Of course, where and that's not going to change. I get it,
and they still have pain.
Exactly. I get it. And so, how do I?
You just added another level to the story by saying if the pain doesn't. She's saying if it doesn't go away, she's going to have the tooth extracted. And that's where the conversation just simply goes back. Well, before we do something irreversible, we have one more onion peel we can look at, and that's the orofacial pain. It could be a neurological problem. So can we please exhaust, if you were my mother, if you were my wife, if you were my child, this is what I would want for you.
Is she on antidepressants?
I'm not going to get into that conversation here, but I will tell you this. I've diagnosed this as a non-odontogenic origin.
Yeah.
And that's, if the endodontist told me different, I would listen. but this is where we have to lean on the specialist here. And as much as we want to help the patient, we also have to have science behind what we do.
Mm-hmm.
And there are moments, just so that my second lawsuit was a pound sand moment also, which was I had restored the patient, full mouth uppers were done, lowers, I opened the bite about 3 millimeters. And the initial discussion was I'm going to verticalize the anterior teeth with ortho. And she wanted it, I was going to verticalize a millimeter, and then finish it with veneers. And she wanted me to verticalize the whole into occlusion with ortho wires. And I said, I'm going to pull the teeth out. So I pounded sand. Went to an orthodontist, and the orthodontist said, oh, we got to remove 3 millimeters of the vertical opening, and that's how we're going to get back into our bite. So they restored the lower posteriors. And that's how you went back into occlusion. Here's the point, though. The point is, these are the types of dilemmas, aesthetics, occlusion, fulfillment, right? And this is why I wanted to have this discussion. Lane, I was thinking of you when I put up that picture, because what seems so simple can lead into a problematic situation once you're in it. Everybody's nice. Everybody loves everybody.
Mm-hmm.
The money's been exchanged. But now 6 months in, the patient becomes symptomatic.
Right.
And you're mid-treatment.
As Michael and I were kind of alluding to, if we don't address the core problems of how the teeth got worn out like that, you've heard me say this several times, but many of your listeners may not have. Broken restorations are much easier to fix than broken reputations.
Yeah.
When our reputations break, are questioned, I can hear it in your voice. It's painful. You ask for fulfillment. Our fulfillment, comes from not only us being happy, but our patients being happy. And so the question of the balance again and scale is do you want to do something? And this comes with experience and time. So, I guess that's why we go through phases of survival and growth and income, right? We need to learn to make decisions that'll protect our restorations. How do you want it to look? How do you make it fit? How do you keep it from breaking?
I think the lesson here, if I can share this through my wisdom, is to, if you truly believe that what you've done is at your best based on your scope of practice, then there are moments that you need to pound sand.
Yeah.
And you stick with that decision and not get influenced by crown it, root canal it. It's going to be better. No, because if I listen to the patient, they don't understand the restorative risks involved with me going back into that tooth and actually damaging the tooth more than helping. Then the argument becomes, well, if you knew that the crown wasn't going to hold, then why did you do it in the first place? So you're never going to be in that. You're always going to be chasing the satisfaction of the patient when it's already been broken.
Right. There's another axiom that's been around if you've been around a long time. Never own your patient's problems. Never.
Yeah. It's I know doctors right now listening to this have had board complaints against them, are going through lawsuits right now. Mm-hmm. And I can tell you, it's easy to say when you're on the outside, but when you're in it, it's hard. Oh. And so we have to respect that notion to be yes, but we're humans, we're nice. Yeah. We want to help all patients. And we've learned through trials and tribulations to do exactly what you said. But it's still a hard moment because ultimately it was a single unit. I mean, the logic is she's asking questions like, are you sure you know what you're doing? And I'm like, didn't you just have 10 teeth that I did for you that lasted 12 years? And you're questioning, and I'm that much better now. You know what I mean? Anyways, but doctors, stick to what you believe to be the right decision clinically. And I'm sure you two gentlemen have pounded sand in your clinical experience as well at times to where, say, you would say, I've been doing this for 40 years. I know what I'm doing, although it might to the patient feel like you don't really know what you're doing. Anyways,
So, can I
Okay.
touch on one thing? Because, we talked about maybe giving people an interim phase 1 kind of appliance so that you can assess what's going on. The same thing is true for relationships. I think one of the challenges in what we see in PPO practices, and many of my clients have PPO practices, if you don't give that relationship time to develop, then you're more likely to have someone say, "Do you really know what you're doing?" I've never had any patient say that to me. Never. And part of that is because I invested the time up front with the patient so that that patient knows that I'm their advocate and their guide. The fact that I'm the technician that may be doing whatever they're doing, or even if I refer them out. I was on the oral surgery staff at Columbia. When implants came into being, I was very, very capable of doing them. I took the course. I did a couple. I said, you know what? I'm not going to do it on my patient. If I'm going to restore someone, especially full mouth rehabs, I want I want the patient to know that they're going to the best person that they possibly can for this issue. I could have done endo. I didn't do endo. I had an endodontist come into my office. I could have done the perio. I didn't do the perio. I had a periodontist come into my office. I didn't do the implants. I had an implant. I had an implant specialist eventually come into my office. Um, Patients knew, and they would come to me and say, "Can't you do it?" And I would say, who would you rather have you do it for you? The person who does it every day or the person who does it once a month? So my point is that the conversations that I had with that patient set up a trust relationship that precluded a lot of the stuff that we see happening. Board complaints? Oh my God. I mean, none of these are good situations. But we're dentists, we're trained in prevention, and building
yeah,
relationships is prevention.
and I think I talk about clinical excellence and maximizing your. I mean, it's tooth number 13. It's for a general dentist who does endo. It's the easiest of root canals. But imagine what that could lead into. Now the conversation changes because why did you not refer the root canal to a specialist? If a specialist would have, you see where I'm going? Now that I've referred it to a specialist, I got more specialist hands in it. I'm more protected.
Absolutely.
Because
Absolutely.
yeah.
Once you get that red flag, once you've assessed that there's not that total trust, you did the right thing.
Oh,
well,
yeah.
and I
Bear
think
the responsibility.
I think you should, and this is one of this on top of the clinical side of this. I think you gain this through clinical experience and just this being seasoned. You're always on the offense. You're never on the defense. Meaning, there was not a moment that I came to the patient and I said, "Okay, maybe you're right. Let me try what you're saying." And let me do what you think would be the right thing to do. You'd be surprised. There's a lot of doctors that lean that way just to try to satisfy the patient.
Well,
And
that's why
so,
I asked you about the antidepressants. So there's
yeah,
a personality type. I'm practicing in Manhattan, and there were plenty of them that they want you to do what they want you to do, and you have to balance that empathy that you have with your clinical judgment, and you have to stick to your clinical judgment
Yeah.
guns.
Yeah. And I tell you what, if I was 5 years out, I'd be a lot more nervous about everything. Where 25 years in, you're like, yeah, I've done my best.
So you know what?
Let it go where it's supposed to go, wherever that is.
So I think we've scared the crap out of most of the younger dentists. They're never going to do. They're never going to do full mouth rehabs again.
Lane,
don't get scared.
Yeah, keep the handpiece in the holster. And here's the point. And I think when you're in survival mode, you take on those cases more. Mm-hmm. You have more production challenge. You have more production. You're under more stress to produce. You're under more stress to make money. You're under more stress to satisfy the management team. So the list kind of goes on and on. But Lane, I know you can't be that quiet for this long. What are your thoughts?
Well, okay. To answer that question, what you just talked about, ability and speed come with time. But here's the thing. Michael talked about it. We're in a rush. You just talked about it. We're focus on production. No, focus on doing it well. Speed comes, right? You just have to accept that. But if you never focus on doing it well, all you do is get faster and sloppier. And that's not a good thing, because that's what bites you in the butt. But if the takeaway of a life in practice, and Michael, I hope you agree with me, it's just 3 simple core principles. Know yourself, know your patient, and know your knowledge. Right? If you can do those 3 things from day one, you will grow to be an exceptional practitioner and reach the kind of fulfillment Michael and I have reached.
Well, let me tell you, can I push back a little bit, Lane?
Sure, go ahead.
Because I did not know myself at 30. I did not know myself at 42.
Yeah.
And I think now I'm 58 today, I can tell you that it's become more clear. So I think there's a self-development side of that changes you as an individual as you go through the journey.
So have you asked me when that happened in my career yet? In my life cycle?
It hasn't yet, right?
It has not.
So here's why I push back on that, is because it sounds like a great soundbite and a great title for books. But the reality in practice, you never really know. You never really know yourself. You never really know the patient. You never really know the future. You never really know if that case is going to fail or if it's going to be successful. Who's got the crystal ball?
So that's the value of mentorship and a coach.
Bingo. Say it again, Michael.
The value of mentorship and a coach.
Yep.
That's because
you guys are going to get me in trouble now.
You're always changing and you're always learning.
I believe you can mentor a doctor, but I don't know if you can really coach a doctor. Can you coach a doctor?
Oh, yes.
What's the difference?
I do.
What's the difference between mentorship and coaching?
So coaching is more strategic and philosophic. Mentorship is more tactical, I believe. Now, if you get a mentor that's great in strategy and philosophy, that's wonderful. And maybe look, you know what? I know you're a sports fan, right? So there are goalie coaches, there are striker coaches, right? There are different coaches for different things. You have to find the person that's right for you. I mean, the mastermind program that I joined was by far and away, I mean, it was expensive. It was like 40 grand a year. It was the best investment I ever made. I'm still best friends with some of the members.
I think, if you don't mind, I think when you talk about sports, I think you can coach a doctor to become a better clinician. I think you can mentor a doctor to be stronger between the ears. That's how I define it. So coaching.
So I do it the other way around. So
Yeah.
so my philosophy is, when I coach somebody, I'm not coaching them to be a better dentist. I'm coaching them to have a better life. So often we dentists see themselves entirely through the dental prism. It's a whole life. No one on their gravestone has Michael Goldberg, great dentist. That's not what life's all about. Life's about fulfillment. And what fulfills me may be different than what fulfills you. That's why my newest book is, the pursuit of happiness. What's happiness? It's different for different people. I thought that I loved dental practice. I got a lot of fulfillment, and it wasn't about the technical stuff. It was about the relationships with the people that I helped, which I still have. I thought when I retired, I'd be miserable. I'm not. I'm not, because my mission in life is helping other people. It didn't make a difference if it were patients or it's other dentists. That's why I'm on here. I want to help people. And I'm concerned that the path that we're now going down, and Lane, you probably will agree with me, the path we're going down with PPO and insurance dependence is not a pathway to fulfillment in practice. It's quite the opposite. And if people don't know that there's still a way of having the kind of practice that Lane and I had, it's going to disappear. We need to keep the model alive.
It's fair to say that you're an author. You've written 10 books. I didn't even know that you've written 10 books. By the way, for the audience, we've never met in person, all three of us. And the other two guest speakers didn't know each other until just now.
Yeah.
So I think this is kind of cool too, right? To bring us all together and have these kind of deeper conversations. Lane, what's your thoughts on coaching and mentorship? Is there a difference?
Well, I don't coach, but I like Michael's definition, right? Life fulfillment. I think that's a separate thing, but yet a part of our professional life and growth. So I kind of like that, life fulfillment, because I think a lot of people don't really understand what brings you happiness. It's so funny. Like, it was a few years ago, I went to my 50th high school reunion. And the coolest thing about, your 10-year and your 20-year, it's all about who's got the bigger belt buckle, who drives the nicest car, right? Get into debt early. The last couple of high school reunions, the people there were the happiest people. They got it, man. It's about health. It's about family. It's about love, right? That is fulfillment. And that is part of our profession, but separate. Mentorship, I kind of view where you're kind of trying to do this in the new social media world, is that, if you've ever heard me lecture, usually one of two things come out of my mouth first. You're looking at the ultimate beneficiary mentorship. So many people helped me along the way. And the second thing that comes out of my mouth typically is, by the way, I'm not lecturing to you young doctors out of the room. I'm speaking to what I wish young Lane knew when he first got started. Because experience, Ambrose Bierce said it the best, experience is the name I give my mistakes. I have made more mistakes than anyone in any lecture I have spoken in front of. I wasn't afraid to try anything. So this is part of that know your knowledge, know yourself. And I think this is where mentorship goes. I mean, again, you shared things that nobody shares, lawsuits. I mean, you don't know how valuable that is, and you want to keep young doctors from experiencing that. So my hat's off to you, because I think you know, no one does this. So when we talk about mentorship and coaching, they're two sides of the same coin, right? And if you want to have the most pocketful of happiness, if you want to use a financial analogy as well, I think you have to have a little bit of both. And I really appreciate where Michael's coming from.
Yeah, I mean, it's you know, I look at coaching as a technical skill, and I, you know, and you know, I brought up the discussion about God, and I'm still like not sure if I want to show this video to you gentlemen, but F it, Tori, go ahead.
I asked God for love. He removed people from my life. Confused, I asked why. He said, because not everyone who walks beside you is meant to walk with you. I will never allow the wrong people to keep you from the purpose I have for you. I asked for peace. He allowed storms. I cried, why? He answered, because peace isn't the absence of storms, it's the strength to stand firm while they rage. I asked for strength. He gave me burdens to carry. Frustrated, I asked why. He replied, strength isn't given, it is built. Just as iron is forged in fire and shaped by the hammer, your character is formed through what you endure. I asked for an easier road. He placed a mountain before me. Exhausted, I whispered, why? He said, because the strongest legs are built by climbing, not by standing still. Then I understood. God wasn't ignoring my prayers. He was answering them differently than I expected. He wasn't making my life easier. He was making me stronger. I didn't receive the life I asked for. I received the life that would prepare me for what lies ahead. Because comfort rarely changes us. Fire refines iron. Trials refine faith. Endure the fire. God is still shaping you.
Did we lose Michael again?
Oh no.
So I share that. By the way, I sent to Michael, if you hear me, it's in Messenger. I sent you the video so you can look at it. He's probably, you know, New Jersey, they don't have internet. I think they just got the internet.
Maybe it was preempted by a press thing tonight.
Yeah. And it leads me to the final conversation that I want to have, which is, and I'm, you know, I'm naive to certain things. We talked about the American College of Dentists. And I want to talk a little bit about that because there is a moral compass. You know, we all have our belief system. But there's also an ethical approach to dentistry as well. Do you want to talk a little bit, Lane, about the American College of Dentists, what it is, what it's about, and yeah.
Well, I think you bring it up because you found out that both Michael and I are fellows in the American College. And if you read their mission statement, that's basically it. They are the moral compass of the profession. So it's very interesting because I think, to go back to your video, you know, what defines us, or as my favorite mentor, my father, said, you know, respect is earned, right? It's not given. And by the way, if it was easy, everyone would be doing it. So challenges define us, that create our pathways. And communication, as Michael was talking about so importantly, is built on honesty and integrity. And so the American College of Dentists award that. And what's unique about it is you don't know what you did in the profession that allowed you to become a fellow. It is a blinded procedure, a double-blinded procedure. You are nominated by a colleague who's a fellow. The review committee does not know who you are, right? You don't know that you've been nominated. And the process plays out based on what you have done to show how ethical you are, how professional you are. It could be in the education field, it could be in community service. What fascinates me that people don't understand, that one of my passions is many people consider to be a fellow in the American College like one of the high points of their career. Less than 5% of our profession belongs to the American College. I'll tell you what my most favorite accolade is in my professional career, in my personal life. I have 5 commendations from the County of Los Angeles for my serving of the underserved in Los Angeles and providing dentistry for them. I'm a Beverly Hills doctor who treats movie stars, Academy Award winners, Miss Americas, and yet one of my greatest pleasures is providing free dentistry. And so whether that defined, why I'm a member, whether my educational background is, I have no idea. But it's kind of a wonderful kind of acknowledgement that at least one part of knowing myself, that profession is a health. It's, care profession. I think most of us became healthcare providers. He's back. So because we want to do good. And that's why when our good goes sideways, like you were talking about earlier, it's so painful. But it just makes us want to do more. Right?
Yeah.
I think
Well,
that's
let me
profession.
let me do this, Michael. I sent you the video in Messenger. If you want to take a minute and look at it.
I saw the video. I had actually
You
seen it before.
Oh, okay. Well, so what it led me into that conversation about the American College of Dentists is that moral, ethical discussion that we're having right now with Lane, and he's talking about how he became a fellow. And you'd mentioned to me off air that you have 5 accreditations or fellowships, and that's the one that you regard as being your top fellowship. So talk to me a little bit about that. I'm sorry, Lane, I didn't mean to cut you off. He came on, so he threw me off. But go ahead.
Sorry.
Did you want to hold on a second? Did you want to finish, Lane, what you were saying?
No,
I think that was.
I think you're going to hear a very similar story. So from Michael.
So it's interesting.
I share that video, by the way, because of resilience, grit. I don't share it because of an ethical, moral debate, but more to say, look, you have to believe in somebody of a higher power, whoever that is, in your father, God, whoever that person is, in order to push through the journey of being a dentist. And that happiness that we talk about, the fulfillment that we talk about, does have to go through some mountains, right? You have to climb those mountains and get over them. And that's part of the journey, not to be afraid of those situations, not to hide and not to want to be challenged in the profession, because the profession will challenge you. And mental health, anxiety, depression, pills, so it all plays a role in how you manage, that patient that's not happy, or that office manager that's not happy, or the divorce that you're going through. How does that affect your everyday at work? It all is a formula that we don't have an answer to. Michael.
So I was very blessed to listen to a guy by the name of Foster Hibbard in the late 70s. And he said something that I think I found to be even more true now when I've studied dentists, as I have for 40-odd years. The dentists, there's a reason I believe that dentists don't have high case acceptance rates. And that is, they don't feel worthy of receiving from others. And what Foster Hibbard said back in the 70s was, you need to feel worthy. If you don't feel worthy, you're not going to get. People won't give you. If you feel worthy, somehow, call it whatever you want to call it, karma, God, you're gonna the stars will align and you will get what you deserve. But you have to feel deserving of it. How do you do that? He said 3 things. One is set up 3 bank accounts. One is your operating expenses, one is your savings, and one is your giving. And and I don't care how much you put a percent, but you have to give. If you don't give, you're never going to feel worthy to get. When I first volunteered, I helped run, I don't know if you know this, I helped run a free children's dental clinic in Jerusalem. I started volunteering there in 1984. In 1984, it's when my practice quadrupled, it went up 25%, and I never looked back. And I believe it was because I was volunteering at the dental school. I was doing stuff, but not like this. I believe that you have to give in order to get. It's biblical, right? It works. It
Gee,
works.
were you listening to what I was saying?
No,
When
I
you
wasn't.
came up?
But
Yeah,
worthy, you have to feel worthy. You know, there's an old proverb. It's an old Jewish proverb that says, "Who is wealthy? He who is happy with what he has." You have to be happy with what you have. That's exactly what Lane was talking about when he was younger and he was struggling. He was okay. You also have to see the light at the end of the tunnel. And I think one of the problems with younger people today, younger dentists, they don't see the light at the end of the tunnel. That's not good.
Yeah, I mean, I think it's going to be interesting because the internet changed the profession, and social media changed the profession, and now I think AI is changing the profession. And I think being that you two, more than I have gone through the different seasons of dentistry, can appreciate the changes and can, compare and contrast what it was like to what it is today. I will say that it'll be interesting to hear that young dentist today graduating and what his thoughts are 40 years from now, as far as how much the profession has changed. So I think that evolution of change should be welcomed. And it's an advancement in our profession. Just look at implant dentistry, look at the 3D printers, and look at, the technology with scanners, and none of that was available to you guys when you graduated. And when I graduated 2001 from Tufts, it was the yellow pages was what marketing was about, and not anything that Lane would know anything about, since he probably never was even in the yellow pages back in the day, right?
I didn't realize you went to Tufts.
Yeah, that's why I asked you to come on the show, man. What do you think? You think I'm going to ask anybody? I mean, I have a Hollywood star dentist here, and I have a Tufts graduate. That's how I roll, man.
So watch this. Hey, Michael, what was the first thing that every one of our instructors in our first semester dental school told us? So sad. You guys all just missed the golden age of dentistry.
I was going to say exactly. Everyone says the golden age was in the 70s. The golden age was in the 80s. The golden age was in the 90s.
Yeah.
There's always going to be a golden age for those who know how to get the gold.
There you go.
Since you guys are a little bit more traditionalist, let me use that term. Lane, do you believe in composite veneers?
You know what? I I love direct restorations. I would prefer a class 2 direct restoration over an indirect. In my hands, properly done, absolutely. I love composite veneers because many times they're a prototype, long-term prototype for final veneers. So I will go back to it depends, right? The old age of the patient, because I don't necessarily want to touch enamel, even though I can minimal prep. But let me put it in its bigger perspective, because this is a global perspective. The better you are with your hands doing it directly in the mouth, the better your communication with the laboratory to give you the indirect restoration that meets your criteria, so you know it'll be aesthetically and functionally perfect.
So do you think that technology today has made us more lazy as dentists, having less clinical skills?
So can we make the mouth is analog?
I'm not going to leave you. I'm not going to let you off easy, Lane. You know that, right?
So who do you think would you okay, in terms of the best aesthetic dentists in the world, and I'm not one of them, would we agree that Ed McLaren is probably one of the best aesthetic dentists in the world?
I don't even know who that is.
All right, he ran the aesthetic.
So he's a CAD CAM guru.
Right, he is in now. But guess what? How he teaches color and texture and tooth morphology, right? Hands-on with composite and wax. Because if you can do it yourself, you can explain it to the laboratory. And that is the missing link, right? Between going from analog to digital. So I think that, again, developing the technical skills, right, that come from doing things direct really advances what you can do in the digital world.
The speed to completion becomes a concern because you got to get the patient in and out of the chair.
Right.
It's a volume-based profession today, and this concept of slow down and do it. Do you know what I'm saying? I mean, that mindset is a little bit.
Why does it have to be?
Yeah.
Well, I mean, look what's out there. Look at the PPO
Yeah, but
game.
why? Why?
Well, it does. You're right. Look, by the way, let me share this with you because I don't think I have yet. The practice that I'm opening, which is my 6th practice, is a out-of-network practice. And so I'm a fan of everything that you guys say, but there's a difference, which is fine. There is my interest is more about access to care. And so the access to care is if I can run a more efficient business, I can charge $950 for my crown as though I've charged $1,500 for my crown and net the same. That inefficiency I'm taking out of my price point and giving it right back to the consumer base. I don't know when this live show is going to end, by the way. So there's got to be, I mean, it's getting dark in New Jersey. I mean, I see, you know what I'm saying? Like, and the internet's already gone out twice. Lane and I joke that it's just, internet is, in California, we just have more things, but
basically you hit on a key point, right? Efficiency rules overhead today. That I don't think there's any disagreement. You have to spend the time to develop the hand skills to do it well and to do it fast. Okay, this is where digital really makes a lot of sense. It allows you to do more dentistry in more time, but you have to master it, right? It's the old business saying: if you had enough time to do it over, you had enough time to do it right. And it's that doing over that will kill us in terms of that efficiency.
So, final answer, Lane, because I don't know if I got it. Final restoration, direct veneer, smile makeover. Yes, no. Are you a fan?
It depends.
See, I can't get an answer.
No.
All right,
well,
Michael. But look, why does it depend? What's the best in dentistry?
That's
it's what's best for the patient.
Good. Yeah. There. Thank you.
That's fair. Michael, don't let him out, man. Come on.
No, it's what best.
It's what we've been saying all along.
when I got out, there was no such thing as porcelain veneers.
Yeah.
Yeah.
All right.
No,
I
I
did
agree.
composite veneers.
Yeah, I agree with.
And as a little hint, whenever I would do a smile makeover, I did a composite mock-up in the patient's mouth.
Yep.
So that I could say, it's going to look better than this, but are you okay with this? And if the patient was okay with that, we would proceed.
Even
Often,
better.
You guys are better dentists than me.
Now you can do it digitally.
Well, you guys are better dentists than
now
me.
you can
I
do
have
it
to say.
on a digital mock.
Yeah, right. Faster and better, right? Just print some temporary veneers and put them on.
Yeah.
So that's what I mean. It's a process, and what I think Michael and I are always complimenting each other and saying is it's all patient driven. Don't lock yourself into a procedure just because you perceive it as the fastest and most profitable, because it may not actually be for that patient.
Well, my point with this is to say that clinically, we have a bias.
Mm-hmm.
And we have a bias towards what our clinical skills are and what we're comfortable with is what we're going to diagnose and what we're going to want to treat for our patients. So the true answer really is not up to the patient. It's up to the doctor that you're seeing what clinical skills that they have.
No. So
do you see what I'm saying though?
No. What if your clinical skills can't match what the patient's expectations are?
Would you go to a surgeon
somewhere else?
Hey, I'm on your team. I'm just telling you what's happening, because you go to a surgical center. And are they recommending restorative?
Oh, no, it's just all on 4, all on X.
Yeah. So, right. So, so I'm trying to speak more for the real game of the profession as a whole, instead of our discussion as 3. But that's the bias. I mean, we have a diagnostic bias towards our clinical skills.
Look at titanium. I mean, everyone had titanium deficiencies, even for tooth we knew we could restore and hold on to, because and so this is nothing new, right? You balance business, and I think this is where moral compasses come in. What would we want for ourselves? What would we want for our own family? And ultimately, there are two. Okay, Michael, I think you'll agree with this. There are 2 business models, right? Get as many people in as you can, do as much dentistry as you can, and say next, or develop relationships with your patients that stay with you your entire career, that always need dentistry. And guess which one actually wins in the long run?
So I would add to that is then use the economics that affords you to give back.
Yes.
To give back. So I'm not as concerned I was never as concerned with access to care in my private practice, but outside of that, I have a social responsibility that I want to fulfill in a different way.
Yeah.
Airlines are really smart. I don't know if you remember, but there used to be two ways to get on a plane, front and back. You know why they changed it? Because they make everyone now go through first class. Everyone gets on that airplane, they go through business class. Why? Because there's no one who goes through business class that doesn't say, I want business class. I don't want that. I want to go back to cattle class. No. The problem that we're heading towards is that we're not going to be able to, that people are not going to know what first class is anymore in dentistry.
Well, I can make this really spicy right now. I can make this really spicy right now.
Anyone who's hanging
let me look. If you follow my social media, like you said something, Lane, that triggered a thought, and the thought is, would any of us go to a general dentist to do a root canal? In general, 95% of the general dentists doing root canals are people that we would not go to. And yet, to your point, Lane, do what you think you would do for yourself and for your family. Would you do a root canal for yourself? Like, would you go to it? You follow me? So with your skill set, would you do a root canal for your dad? No. You'd
No.
refer. Would you allow somebody with the same skill set to do the root canal on you? No, bullshit. You'd refer. So you have to really understand the radical self-responsibility in what you said. And we don't take radical self-responsibility
Right.
because we got to hit the production numbers.
Mm-hmm.
Right? And so that's the challenge. Clinical excellence is not a nonchalant, nice way or soft way to say, this is what I would do for my mom, or this is what I would do for myself. Really? You would do a root canal on yourself? Really? No. Now I'm saying with the same skill set, a clinician with the same skill set. So it's an interesting conversation. And this is why I've really enjoyed the talk we've had. And sorry, Lane, I know I'm trying to end this freaking thing, and it's I told you guys 60 to 90 minutes, and we're 2 hours in. So, but I apologize for that. But Lane, do you have anything you want to say to that?
No, I think I love this conversation. Again, this is how colleagues interact, right? Agree, disagree, go off on tangents. I can tell you, I have learned so much in thought processes, in the way I want to think about things. And there's just so many pearls here. I mean, so many that were missed. And Michael brought up a really big one that I always promote: read outside our profession. Read some philosophy. It just makes you a better human being. The better person we are, the better dentist we become. And again, I think it's nice that you picked a couple of old farts, who are at the end of their journey. We trust me, we didn't forget how hard it was. It wasn't easy, was it, Michael? Honestly, we came out, pardon my French, we came out of school, man. AIDS hit right when I got out of school. And I don't know if you remember Kimberly McGallis, the preacher's daughter's dying a little bit every day on TV, and they blamed a dentist. You don't think that was a tough nut to crack? So,
Well, gentlemen, I want to thank you.
Thank you.
I want to thank you for coming on. Sometimes I don't know where I'm going with the direction of all this, but sometimes it becomes clear. And it's just a simple, I appreciate both of you for your time. I have a tremendous respect for doctors that are 40 years plus out and retired, or still maybe practicing. I don't know. But look, you guys are still at some level, maybe not clinically practicing, but you're still fully engaged with the profession, and that's beautiful to see. Michael, what's next for you? Book number 11, book number 12. What's coming up, man?
I'm going to start a mastermind group. It's going to be called Be the Authority.
How could somebody get a hold of you to learn more?
theliberatedpractice.com. Easy.
Lane, what about you, Lane? When you teach and when you educate and when you lecture, do you feel like you're mentoring the audience?
Oh, yeah. Like I said, I'm speaking to what I wish younger Lane knew.
Yeah.
Yeah. Learn, success is a terrible teacher, right? We really learn from failures. And so, but failures hurt, including ones that end up in litigation. So, what I'm trying to do is help younger doctors prevent or minimize the mistakes I made when I was there in their pathway, in their career. And so, that's the joy of continuing to teach. And so, and I'm blessed.
If I go and get my third lawsuit because of this tooth number 13, I'm coming to you guys. So
you have 3 endodontic expert witnesses on your side.
I know. I got you, man. I know what's going on. I'm cool. Gentlemen, thank you so much. I hope you have a wonderful day. And
thank you.
And you still have every right to still talk shit about my posts and comments. Feel free. I'm sure we'll revisit again another time on another show, but thank you so much.
They always bring up conversation. Isn't that what you want?
Yes, absolutely. Thank you, gentlemen. Wow, that was fun. Yeah, these are the type of conversations I want to have. I want to have real talk, raw, and I hope you learned something. I hope you learned something from all of it. I'm Dr. Shaheen Safarian. Next week, I have Dr. Todd Snyder on. And I'm really excited to talk with him. He's gonna, I'm a fan of all this this out-of-network cash fee-for-service relationship building, and Todd's gonna blow it up with what he's doing in Vegas, and I had a chance to meet him in person at the CDA this past couple of months ago. In either case, I'm Dr. Shaheen Safarian. Love the profession. Always have a smile on your face.